Now there is an FDA-approved high-frequency ultrasound, digital ultrasound scanning device, and it's called the Insight 100. It's made by ArcScan. My satisfaction is that, something which I've used in my practice daily since I set up the London Vision Clinic in London in 2001, and when I say daily, I mean daily. It's been helping me screen patients. It's helped me deal with complications from elsewhere that no one could diagnose, and then suddenly, it's not because I'm smart, it's because I have the data. I can say, well, this is what's wrong. Therefore, it tells you how you can fix things. So it's made me into a kind of someone who has more information. And I'm so glad that now anyone can go out and, for the same price as a Pentacam or any other sort of normal eye scanning device, you can now have all of this information in your office. I would say the main applications that we use the Insight 100 for on a daily basis, the main applications, the number one is screening for keratoconus. And I think a lot of people are now aware that the epithelium over a keratoconic cornea is different from a normal cornea, and a subset of those are now convinced that screening for keratoconus with tomography alone, that's front and back surface with algorithms, is going to miss early keratoconics because the extrusion, if you like, is not sufficient for an algorithm to pick it up. The beautiful thing about combining the latest tomography algorithms with an epithelial thickness map is that the epithelial thickness map can, with high-frequency ultrasound, can show even a 1 or 2 micron focal thinning in the whole of the 10 millimeter zone. And that focal thinning associated with any back surface change that is even slightly abnormal, which you wouldn't in and of itself call it abnormal, but associated with a back surface change that's eccentric and a little bit elevated, that is diagnostic of keratoconus. And the number of eyes that I come across who have totally normal topography and tomography, which then pass through the epithelial thickness screening, and then we detect the keratoconus, is not huge, but it is the ectasias without a cause that I avoid. Some people would say more, I would say that's the most important, but some people will say the most important thing is that you can take a cornea that has an abnormal topography and prove that the inferior steepening is not keratoconus by demonstrating that the epithelial thickness is thicker over the region of the steepening inferiorly. That excludes keratoconus because you cannot have thicker epithelium over a cone. The cone will cause epithelial thinning over it by definition. So you can exclude keratoconus with total confidence, even though a topography looks very scary. And that category, we did a 1,500 eye screening study where we got a little over 9% of the eyes where we thought they were suspicious. And when we looked at the epithelial thickness maps, 14% of them were, they were keratoconics, no surgery. 84% of them, not keratoconus. And those eyes got surgery. And we followed them for years, and they're stable. The market in the US for for ICLs is not as developed. And it should be, because the ICL is approved. Ask me why I think that is. I think it's because people are worried about sizing issues. I think that doctors have some trepidation about putting a lens in, the size of which is estimated from external ocular measurements, like the white to white, the angle to angle, things that you can measure, indirectly predict what you think the sulcus diameter is. And so we've done a lot of studies on this. And obviously for the first few years, we were busy trying to find the correlations between the white to white and the sulcus to sulcus, which are poor, between the angle to angle, which you can measure with an OCT or a Pentacam, and the sulcus sulcus, better but not as good, but not great, and a multivariate regression analysis model with everything you can possibly imagine shoved in and see what survives. And even that Even a multivariate predictive model can only predict the sulcus with 75% certainty within half a millimeter. So 25% of the eyes with the best model still results in a wrong estimation of sulcus to sulcus of half a millimeter, which is a lens size difference. So what we did was a prospective study with Carlo Visolo in Italy, who had a prototype Artemis II high-frequency ultrasound scanner. And he developed software to size ICLs based on sulcus to sulcus measurements. So in this study, the target volt was 350 microns. The mean achieved was 360 something. If those same eyes had been given the ICL sized by that eye's external measurements, the volt height would have been 160 microns, because you can back calculate all this. The standard deviation of the volt of the whole population, about 300 eyes, was something like 160 microns. The standard deviation would have been, had we used the star formulas, 300 microns. So we get much better accuracy and much better precision in terms of volt height control, and volt height control is the safety of the ICL. And the ICL is a phenomenal technology. It's very safe and very effective if it's perfectly sized. There's a whole area that one should mention. It's not developed yet, but it will be. And that is because the ArcScan Insight 100 has a 6 degrees of freedom scanning system, it can actually scan the entire capsule of the crystalline lens and the zonular complex. So you can actually image and determine the volume of the lens and all of its parameters, all its equators, all of its parametrics. This means that it is finally possible for people who want to try and crack the elephant in the room problem with IOL power calculations, which is the elephant in the room is the ELP, right? ELP, elephant. Yeah. But it is the elephant in the room. People have tried to tackle it, but they've never succeeded because they've used lower resolution ultrasound, yeah, UBMs. And now with a high precision device such as this, the exact localization of the crystalline lens can be determined pre-op, and it's just a matter of time before clever cataract surgeons start getting into iterating what happens to an IOL based on those measurements. And it's not going to make IOL calculations 100%, but it's definitely going to improve it from where we are now, because ELP is the single most important factor that we're not taking account of in IOL power calculations. So as you see, this is a high-frequency ultrasound is the fact that it's now commercially available means that we're kind of entering a new era for anterior segment eye surgery. And finally, there is a micronically accurate biometric device that can enable any surgeon to do precision surgery based on precision measurements. And so, you know, I've published over 100 papers. That's just me. Wait till the community gets a hold of this. I think it's going to be, we're going to see a new era in eye surgery.